Good afternoon and half a day. The Committee on General Government Operation and Appropriations now called to order. Today is Tuesday, May 21st, correction. The time now is 2 o'clock. In compliance with open government law, the notice for this public hearing were posted on the Gov Guam public notice portal on GTA TV, channel 21, Docomo channel 117, and live stream on the Guam Legislature YouTube, and disseminated via email to all senators and all main media broadcasting outlets on Monday, May 13 and May 16. The agenda this afternoon is Bill 236-37 COR, Committee on Rules by request of I Magaʹhågan Guåhan, the Governor of Guam, in accordance with the Organic Act of Guam. An act making appropriation for the operation of the executive branch of the Government of Guam for fiscal year ending September 30th, 2025, making other appropriations and establishing miscellaneous and administrative provisions relative to the Guam Memorial Hospital Authority. At this time, I ask the members of the Guam Memorial Hospital Authority panel to rise and be placed under oath by the Sergeant Arm. And if there's any other staff that might speak, please rise so that you be sworn in. Anybody else? Otherwise, don't offer your opinion because you won't be allowed to speak. Only got one. Okay. There's the floor.
Under penalty of perjury, do you all affirm that any and all information you provide today, whether it be verbally, electronically, and in writing, be the truth, the whole truth, and nothing but the truth? Mr. Chair, under oath, you may proceed.
Thank you. The general rules for this budget hearing. Please provide my legislative staff with any document for photocopying and distribution. Panel members are asked to remain in the room for question or for additional testimony as may be desired by members of the committee. Questions and testimony shall be confined to the substance of the agenda, which is the bill of the Guam Memorial Hospital Authority. Personal inference as to the character or motive of any senator or any individual testifying is not permitted. Any violation of the general rule will result in removal from the budget hearing. That's from both sides, okay? Proper form and decorum shall be practiced by all present in the public hearing room for these proceedings. Individuals who fail to maintain proper form and decorum will be restricted from participating and will be removed from the room. When you speak, please make sure that the microphone is on and that you speak into the microphone. Please state your name and your title for the record. I'd like to acknowledge my colleagues that have joined me this afternoon. We have Speaker Therese Terlai, the Oversight Chair of the Guam Memorial Hospital, Senator Tello Tadivi, my Vice Chair, Senator Sabina Perez. And with that, I ask the Guam Memorial Hospital panel to please present their budget, their testimony. Thank you.
Buenas, Yan Hafaday, to all of our senators of the Guam legislature and to all who are watching or streaming on this particular YouTube channel platform. It is with deep humility that we as leaders of Guam Memorial Hospital Authority are here with you today. I must first give the gratitude and respect to Ms. Lillian Perez Posadas, who is finishing up her leave and will be back serving our hospital as our hospital administrator by the end of this month. My name is Dr. Dustin Prinz, and I am currently serving as the acting hospital administrator. I am so grateful and honored to my executive leadership team. To my left is Ms. Yuka Hechanova, who serves as our chief financial officer, and to her left is Jordan Paloon, who is our legal counsel at GMHA. Behind us are very gifted leaders at GMHA. Yuka and I will present our budget to you. I will start this presentation and attempt to fill in any apparent possible gaps. I must mention that the governor, Ms. Lillian, and other members of our executive team, including our board of trustees, are aligned with what we are about to present. I begin by saying healthcare is a rapidly changing industry that must continuously to adapt as new patient needs emerge. Technologies and techniques are updated and reimbursement models continue to evolve. A strong healthcare budgeting process is what allows us as leaders to plan for the future and establish priorities around care and clinical departments. This is an important tool to understand where funds are best spent and how to allocate capital among various departments and projects. Thus, helps us to be more efficient in delivering effective and efficient patient care, which brings us to where we are at today. There are budget-related challenges, both internal and external. Examples are unpredictable economic events, such as the 2020 COVID-19 pandemic, which can render what we had as static budgets to be outdated and definitely inaccurate. Changes to reimbursement and payment models, including declines in Medicare and Medicaid reimbursement. Development and adoption of new technologies such as telehealth and home-based medicine, which is still being defined, even in the best of cases. Labor shortages and increasing costs, which has not gone away since the pandemic, but has only increased. Supply chain issues and interruptions, such as even prescription drug shortages. Some factors are also truly beyond our control, which we have seen are changes in patient volumes across various departments' services, which can affect service line budgeting, rising interest rates and inflation, to name a few. Even with these challenges, we must be accountable with our financial control and management, with examples of factors like delineating personnel compensation, medical supplies, equipment upkeep, and other operational expenditures, and compare these costs with revenue projections. We need to do this to strengthen our transparency, which enables we as GMHA to vigilantly monitor and regulate spending while reviewing areas to reduce waste. Another challenge is allocation of resources so that we monitor risk wasting resources on unneeded equipment and falling short on supplies, leaving staff unprepared to adequately serve our patients. Our hospital needs to operate more effectively to plan for contingencies and mitigate the risks associated with the unpredictability of the healthcare industry that we live in. Our budget seeks to provide a performance evaluation of sorts to help track trends in key performance indicators, such as cost per patient, patient volume, financial returns on investment, and any other relevant financial metrics. We have to be consistently looking at underperforming areas or inaccurate forecasts that should be analyzed in greater detail to find where estimates went wrong and what can be done to minimize these errors in future budgets. I hope that this fosters a culture of open communication and coordination, not only across our various departments' divisions, by involving different stakeholders in the budgeting process, including managers, accountants, top-level decision makers, but also with you as the legislature, the governor's team, Office of the Public Auditor, and the Office of the Attorney General, who all of us, we all serve, who is our people on this great island. We as GMHA must be accountable to present a well-structured hospital budget to provide a clear overview of our organization's financial health, enabling not only you, but also our governor as well, who gives us the appropriation amount to function as the only public hospital on Guam. The amount that is given to us is what we need to stand by and then be caretakers and stewards, to be leaders, to make informed decisions about resource allocation, investments, cost-cutting measures, and more by identifying areas for growth and potential risks. A challenge to this is ensuring that the financial resources are optimally deployed in support of the long-term vision of who GMHA is and who we serve, while seeking to maintain better financial health than we are in now. Our financial statements that will be discussed are typically standardized and formatted to accommodate relevant accounting standards, such as generally accepted accounting principles. We must adhere to standards and deadlines for monitoring and reporting on financial data, including revenue from government entities such as Medicare and Medicaid. A properly crafted budget can also simplify audits, both for internal analysis and from external regulatory bodies, by showing cost and revenue breakdowns and exactly how funds were spent. We seek to build an effective budget that improves both long-term stability and long-term growth, short-term stability and long-term growth prospects through setting goals and limits for expenses and by optimizing how funds are split between day-to-day obligations, such as wages and supplies, and investments in long-term assets, such as facility capital projects, equipment repairs, and improving our technology infrastructure. Currently, we experience supply scarcity or outdated and broken equipment, ultimately causing reputational harm due to what is inadequately perceived, yet probably warranted from the public eye as poor or unreliable patient care. GMHA does not nor cannot operate in a bubble, and neither can our budget. But unfortunately, it may come across as this. We must consider the demographic and socioeconomic attributes of our community to effectively budget and allocate resources to meet their needs, which in essence can strengthen our partners in health on this island. Our majority of pain mix is an area with low insured population that must rely on public health, and all those who help analyzing community data, conducting community outreach, and collecting feedback to see how we can meet our community's unique needs. The impacts of our budget and appropriation presents us with major decisions that directly affects our patients with a direct impact on patient experience, informing patients' encounters with the healthcare system, as well as the tangible outcomes of their treatment. We must elevate patient care, increase patient satisfaction, and enhance health outcomes. We are accountable to this, even when resources are scarce or funds are tight. GMHA must provide the best care possible and ensure that our patients know that their needs will be met. Thus, we must be transparent to our patients with how the amount of the appropriation from the governor's office and from you as a legislature, and how and what we offer, and giving a realistic timeline on when and how we will be able to provide the necessary services. As such, if GMHA is unable to meet our patients' needs, outcomes are likely to suffer and patients may seek care elsewhere, or maybe not at all, hurting not only our long-term success and potentially harming patients' overall health, but also being a cause for failing of our health care on our island. Because of this, our budget must always prioritize patient safety and care quality, even in the face of financial constraints. These allocation decisions will also impact the organization's performance and staff morale, and are especially important during volatile economic times, such as during supply chain disruptions and inflationary periods, which can increase costs and reduce stock levels. We must consider our unique circumstances when setting budget targets by assessing what we do well and how best to allocate resources. This strategy will attempt to be shown as we discuss our operational budget, but is also true when we discuss our capital budget, with the goal to improve our standing by investing in state-of-the-art equipment and much-needed renovation in areas we must be strong in, such as our maternal child health and pediatric services. An example of this is with the upcoming maternal child health NICU renovation. An example is to seek to be the best neonatal care in our region, which may then choose to emphasize that department's needs over other fields or services of medicine within our hospital. Our budgeting decisions affect more than just our hospital itself, extending into the wider community. I must be transparent that we are not good at this, but we must strive to be better. We must partner with our other agencies, whether it be public or private, thus even potentially budgeting for community outreach, marketing strategies focus on awareness and preventative care, which not only strengthens the healthcare on our island, but also can cut down costs. We must budget for reduced rate or uncompensated services by increasing funding for procedures or equipment that may make care more accessible and affordable for underserved and often underinsured segments of our local community. We need to look all together in forming strategies that emphasize preemptive care, which can help reduce the impact of community health problems on a hospital's budget when outbreaks and other widespread health issues occur. We must be true to who we are. We will be presenting to you with how we look at our services. We are accountable to do all we can to not only match or exceed our revenue projections within our control, but also we are stewards to the appropriation from you as a legislature and our governor. We currently are not the best partner with our valued vendors, which definitely has kept me up at night because it just is not a good way to conduct business. We must accept that even if we attempt to undergo the grand rebasing and other measures like this, we still have a very aged facility in that we can never command the rates that we could if we had a newer facility with updated equipment. We also must accept that with our paying mix, could we ever collect more revenue? Questions like, would it be prudent and cost-effective to outsource billing collection services and being real with what we collect as to who we are? And what are the primary tenets that we must have to serve our community? Are we strictly an inpatient facility focusing on shorter, less complex admissions? Or do we continue what I feel we are doing well in, just not always seen as revenue generating, with our inpatient and growing outpatient facility to progress with our outpatient services and even providing those more costly to us, long-term, more complex admissions? We will be presenting this and attempting to form and craft the primary question as to who is GMHA and what are the primary services that GMHA must provide to our island, serving as our island's public hospital. There will be 3 options that we will present, and we will attempt to map out how each of these options could look like when thinking about hospital operations. There are handouts for you that you should have, which go into greater detail that the slides will not. So as we discuss these options, you have in front of you some substance. With this as our backdrop, I will now proceed with the first slide. Next slide. So as you see here, the enabling legislation of 10 GCA says maintain and operate a facility providing acute, chronic, and all other healthcare services, including those services specifically provided by contract for the Department of Mental Health and Substance Abuse for the people of Guam. So I present to you our thoughts on what are primary tenets of GMHA. Remember these as we go throughout our budget. Is maternal child health, pediatrics, ER, laboratory, radiology, pharmacy that are associated just with those, NICU, PICU, surgical and medical surgical wards, short-term admissions. Secondary tenets of GMHA that now we offer are ICU and telemetry wards, pulmonology outpatient services, gastroenterology outpatient services, interventional radiology, podiatry, interventional cardiology, telemedicine services, and even neurosurgical. Next slide.
Good afternoon, Senators. The FY 2025 budget request.
Ma'am, can you please state who you are? So
I'm sorry,
first-
Yuka
first-
Hechanova, CFO.
Okay, thank you.
So GMHA is requesting a total of $74.3 million for FY 2025. Our expected funding sources in FY 2025 will not be sufficient to cover the projected operating expenses. Although the governor's executive budget provides $32 million, a shortfall of $42 million is projected. We're asking for the shortfall to be appropriated to GMHA through the general fund. The most notable increases are expected in personnel costs, contractual, and supplies. Personnel costs for FY 2025 are expected to be $14 million higher than FY 2024 and include increases in nurses' pay due to the new pay rates in the nurse pay plan effective April 1st, 2024, and employee fringe benefits due to the retirement rate increase. Contractual costs are expected to be $8 million higher due to the continued need for contract travel nurses and higher costs for physicians. Supplies and materials are expected to cost $3.5 million more than this year due to increases in the cost of drugs, oxygen, and other medical supplies. Next slide. The slide before that, please. Thank you. This illustrates how personnel, contractual, and supply costs have risen since pre-pandemic 2019, with personnel costs climbing the most. According to the American Hospital Association, issues such as persistent workforce shortages, fractures in the supply chain for drugs and supplies, and high levels of inflation have created an environment of financial uncertainty while many hospitals operate with little to no margin. Labor costs continue to be the largest percentage of hospital expenses. Next slide, please. For billings and collections, they've improved in FY 2024 as we recover and bounce back from many extraordinary events in FY 2023. FY 2023 began with the go-live of the new EHR, and we had expected a decrease in billings due to the implementation. But this was followed shortly after by the network shutdown in March 2023, and 2 months later, Typhoon Mawar. All these events had significant impacts on billings and collections. These impacts required us to obtain immediate cash relief from Medicaid advances. In total, GMHA received $22 million in such advances from April 2023 to October 2023. And to date, we've paid back $15 million and expect to pay this obligation before the end of this fiscal year. Our coding is current. Our billing is also current, except for some ER and outpatient Medicare claims that we're catching up on and concurrently billing with the current claims, and this is all done by our billing team. Next slide, please. Our accounts payable as of May 17, 2024, the $30 million funding that was provided by the legislature in October 2023 through Public Law 3743 brought tremendous relief as we were able to finally pay vendors and release our credit holds. However, because of the lack of funding, our current payables are now at $14 million, with the largest amounts owed to vendors for supplies and pharmaceuticals. GMHA's current monthly cash requirements are around $16 million a month, and total cash receipts average about $13 a month, including the monthly allotment of $2.5 million from DOA. This leaves about $2 to $3 million shortfall every month. Next slide, please. Accounts receivable as of May 17, 2024. Accounts receivable have also been improving in all areas except self-pay. We continue to strengthen our relationship with our payers and work closely with them to resolve billing issues quickly. Although we have been able to help self-pay patients apply for Medicaid, old self-pay balances are a concern. We are planning to outsource collections of old accounts while our collection staff work on current accounts. Another issue plaguing GMHA is social cases that also have significant balances on our AR. Increasing our TEFRA Medicare discharge is also in the works. However, this is not a guarantee. If rebasing is possible, the new rate is not expected to materialize quickly enough. Our FY23 Medicare cost report showed that the current target rate per discharge paid to GMHA is $12,600, while the actual cost of discharge was $24,300, a difference of $11,700 per discharge. Since FY 2020, the start of the COVID-19 pandemic, the gap between our Medicare reimbursement rate and actual costs has significantly increased. Next slide, please. In FY 2024, we see more self-pay patients moving to Medicaid, which is what we would really prefer. We've assisted uninsured patients with applications for Medicaid or MIP coverage through a collaboration with the Department of Public Health. Most of our patients are covered by Medicaid and Medicare, as can be seen in the graph. The blue areas are what we term the 3 M's of Medicare, Medicaid, and MIP. But the payer mix explains our challenges with our reimbursements from Medicaid and Medicare. We are limited to a per diem rate for inpatient charges. With increases, and our per diem rate right now is $1,674 for inpatient stays, regardless of charges incurred. With increases in labor and non-labor costs, this has a significant financial impact on GMHA to provide care for our patients. Next slide, please. This year, we received $30 million as emergency funding to pay vendors for older invoices. As mentioned, FY23 was an especially challenging year for cash flow with disruptions to billing and increases in costs for labor and supplies. FY 2023 provided us a $5 million subsidy for specialty doctors as well, which has been allocated to procuring the special equipment and supplies needed to provide such services. For this fiscal year in FY 2024, we are projecting another shortfall of approximately $25 to $30 million. Next slide, please.
Now on to the three options. First option, is to maintain. This is to keep the operation running the way it is. But what I am proposing is a need for a fixed annual subsidy from the general fund of 60 to 80 million a year. Make note from the fourth slide, UCA presented at a minimum is 50 million just to keep it going. The reason why I said 60 to 80 is to help with the maintenance of the hospital, to also look at within the facility, but also to look at ways to actually start some CIP projects and to do things like that. And this fixed subsidy will be until the new hospital is built to truly maximize the rebase and the increasing the TEFRA ceiling, which would be with the newer facility. It is very similar to the subsidy back in the late 1990s under the term from from Governor Guterres. Back then, it was 30 million a year subsidy. And we must contain operating expenses by managing labor spend, by optimizing schedules, reducing overtime. We must be accountable to increase operating budget transparency and accountability, promote efficiencies by leveraging existing automation. Again, this is option one. Option two, next slide. Now we are speaking about sorry, Dr. Prinz, there is no way that you could ever ask for 60 to 80 million from the general fund, no way. So what if the subsidy is like 30 million? Let's just say that. Then we must look at cutting. We will have to do cost containment, which means to cut most of the secondary tenants, which is on the second slide, which is the outpatient services, which be about 20 to 30 million a year. GRMC would have to absorb the services cut. But honestly, I think there are some creative solutions though with this. I present to you potential opportunity for public health to absorb the outpatient services. This also may be a good thing for public health to grow their services and to actually build upon it and to be able to fully apply for many grants afforded to public health that we cannot as an acute care facility. But we still must contain operating expenses by managing labor with the cut services.
Next slide, please. These are the cuts that we are proposing for option two. The first column with outpatient clinics includes our clinics for gastroenterology, pulmonology, and cardiology. Other services include neurosurgery, urology, orthopedics, telemedicine, ICU, and travel nurses. And we estimate these cuts will save about $32 million. Next slide, please.
This is the sad one, but I have to be real, transparent, and accountable. This is close. Let's just say that if the subsidy is close, maybe less than 10 million, then it really truly does come down to cutting all of the secondary tenants, close them all, and to also do the telemetry ward as well, which means that we become a service provider focused on shorter admission stays. Remember, I was saying that before in my testimony, and looking at medical, surgical, and surgical wards, and to be basically a maternal child health pediatrics ER. The question I ask is this what the people of Guam want? Next slide, please.
So for this option, if the subsidy falls below 10 million, we would close, as Dr. Prince mentioned, the telemetry and ICU wards and become primarily a service provider for maternal child health, pediatrics, emergency room, and medical surgical wards. We're also going to cut interventional radiology services. So this will save us an additional $20 million.
Added on with option two costs as well. Next slide, please. Here are our CIP updates, projects. You actually have a handout of all of the updates. Ms. Rodalyn Garrido, as well as Mr. Zaldi Tugati, they actually gave you some really great handouts just showing kind of where the ARPA funds are located right now, where we're at with that. And if you have any questions regarding that, Ms. Rodelin would be happy to come up and speak to that. With that, Senator Joe, we have presented our budget to you with 3 options, and we're open to any questions. Thank you.
All right, thank you. I'd like to also recognize colleagues that have joined us this afternoon, Senator Brown and Senator Fisher. And with that, I'd ask, one simple question I've asked before. On the reimbursement on the federal side, I think it was Medicaid or Medicare, how is that working out? Were you able to work out whatever the system is to get the 100% reimbursement? Or what is it, what needs to happen to get that to work?
We need to request from CMS to do the rebasing for us. So right now, I am going back to the records from the other rebasing that we did in 2015. The research, that even took over 10 years to accomplish. It took a very long time of back and forth between CMS and GMH. GMH finally hired a consultant back in 2014 or 13, and after about 2 or 3 years, they were finally able to get the rebasing approved by CMS.
And what is that percentage amount of reimbursement that GMH gets?
What happened was we were rebased, meaning that we went from 1992 Medicare costs reimbursement to 2014. So instead of being reimbursed based on older costs, newer costs are reimbursed. So that's the whole point of the rebasing, is to bring us more current with our current costs and to get reimbursed based on those costs.
But even if we did the rebasing, it would only go to 2018, which is pre-pandemic yet.
No, but what is that percentage amount? If you're supposed to charge $100, what would you get back? $100, what do you get back?
Ideally, yes.
You would get back 100?
But it's a complicated computation. It's not where they're going to pay the whole, like if the bill is $10,000, they're going to pay $10,000. They'll actually calculate per diem rate that will be more closer to match what our costs are. So the per diem rate will be calculated to reimburse us for the cost, but it's not going to necessarily pay for the full bill.
What are you getting today?
Well, like I mentioned in the slides, we're about 11,700 short per discharge.
Which means what? I'm trying to get to a number. You know, like if you're going to tell me you're getting 50% reimbursed, then just say that. I mean, if you're getting 60 or 10 or what, I just want to hear what the amount is.
Right now, we are getting 33%
About 30%.
with Medicare, Medicaid, and MIP.
Okay, thank you. Madam Speaker, Oversight, would you like to be last? Senator Tello, do you have any questions, comments for the panel?
Mr. Chair, this is quite, well, good afternoon first to my colleagues. This is quite a bit of information. I think I'm really shocked because of all my time here, we've been pushing for GMH to come with a more realistic amount of funding for the hospital to keep it going. And they've always stayed within the governor's request on appropriation. And we sit behind here encouraging you to put a true figure in front of us. And right now you're putting a true figure of $50 million. $50 million. I mean, then you went through this whole, so Mr. Chair, it's a lot to intake, you know, a lot, especially when you have your options. You're throwing us options. You're not throwing us, this is what we plan to do. You're throwing it on our table now to say, okay, well, here are the options that you have. And, you know, you haven't said we can work with any of these 3 options that you put in front of us. That's not our job. Our job is to listen to what you are going to do to fix the hospital, to provide the services that is needed at this hospital, and how much it's going to cost you. $50 million is what you're throwing at us right now. And then I'm going through all these other variables regarding collections, for instance. Let's go to billing and collections. And I'm sorry, but with numbers, it was going so fast, you know, when you're explaining this, and you have to trying to go back and read what you said. You know, I don't know, maybe the faster you speak, you know, it might just go over our heads that we don't even know what to ask you. I think what we're supposed to do is try and work together here. make us understand what is truly needed. Instead, you give us options, bad, worse, and even worse. So let's start with billings right now. It gives my colleagues an opportunity to go over everything that you've thrown to us. But with billings, you have here in October 23, it shows billed at 25 million, budget 11 million. Actual collection is 11,414,000, and then Medicaid clawback was 0, right? That's what I'm reading here, right? Okay. So you're showing here throughout the actual, December 2023, billed was 20 million, budget 11, but actual collections was only 5 million. That's a substantial amount that's, it's almost like, here's a big issue right here. So let's start there. What is Guam Memorial doing to try and capture this revenue? And what have you done in this last year? And what in your proposal are you recommending to collect these bills?
Thank you, Senator, for that question. In December, we were experiencing a lot of setbacks from many things happening in the year. We did have a huge backlog in our claims, in coding the claims. And so immediately in January, we had put together a task force to address all of the coding back billing.
I'm sorry, that was when?
That was in January this year.
Of this, just this year?
Just this year, yes.
But yet this has been happening since December 2023, January 24. Okay,
Yes,
go
so
ahead.
because the numbers were so low, we really had to jump on what was going on.
So a task force was
Yes,
formulated?
so by the end, we gave ourselves about a month or two to get through all of this, and by the end of February into March, we had completed most of the coding, and so we had about $25 million in claims that were not coded. This was our backlog, and now today it is down to about 3.5 million. So the coders were able to work extra hard. We even put additional staff on that task force that had coding experience, and they started helping us code, and we got this down. The thing about this is after these claims are coded, a lot of the claims had jumped onto the billing side, and so now it's up to the billers to push these claims out. And so they've worked through most of it, but there are still about $2 million of claims in Medicare for the ER and the outpatient that they're still working on, but they are still within timely filing, so once we push them to Medicare, we will still get reimbursed for those. But we did put a task force together to address this. So as you can see, as the months go along, the collections have been improving, and the billing has also been very good.
So the last one is, okay, so when we go up the chain from October, November, December, then in January 2024, February 2024, March, April, May, you're saying that the billables, right, billed is 15 million.
To date.
Okay, to date. So that $221 million total is now subtracted by 76 million, so you still have quite a bit in collections.
Well, even if we bill all these amounts, we do not get 100% reimbursement.
What is your percentage?
Right now, it's 36% that we're overall, because of the amount of Medicare and Medicaid patients that we have, that we just get reimbursed on the per diem rate. That is where most of our patients lie. So our reimbursement challenge lies right now with there. When we bill the private insurance companies, we get almost 100%. The only thing we won't get paid is anything that's on the patient share and anything that's rejected or denied, or if we made an error, then they will not pay. But the reimbursement rate for those are very high, but we only have about 25% of our patients that are covered under this kind of insurance.
And that is why, okay, Mr. Chair, can you come back to me? I have an emergency call.
Okay. Senator Parrish, do you have any questions?
Yes, thank you for this presentation. Yeah, I was kind of interested in seeing, in regards to your second slide, Dr. Prince. So who do you believe GMH should be in this framework, I guess, more philosophically? And I guess basically, who are the patients? What do you see as far as the type of patients coming in?
Thank you, Senator, for that question. This has been in the making for a while. In my 8 years here on Guam, I have really looked at this because the enabling legislation's there, and it shows us that we need to provide acute, chronic, and all other healthcare services, right? What does that all other mean? To me, all other means what can we fund? What can we do? Because the problem is, Senator, is that we got to look at what we can do ourselves to really truly balance a budget. I don't know how many budgets that have come through here that there's never been a balanced budget. We've never balanced a budget, and that concerns me a lot. And so that is why I'm just thinking about, because we do have other partners on this island, correct? So the question has to come. There's always like this weird term called reduplication of services. That's what gets thrown around a lot. So the question is, we have to ask ourselves as the public is what do we provide? Do we provide the same services at the private institution? And that's called reduplicating, right? So that's why I really looked at this along with my team to really look at what are the primary tenets that GMHA has to do. First thing that comes up is maternal child health. We are it on this island, right? We have to do that. Pediatrics, we have to do that. Having a well-functioned ER, we have to do that. NICU, PICU, and even having shorter-term admissions. The reason why I say that is because with our rates today that we have, we can't make money on those that stay longer than 14 days. We have to have admission stays that are lower. That's just the brevity of it. So that's what I am saying, is that I want to provide everything. I think we all do a great job. I trust all our doctors that we have at GMHA. I trust them. I trust the nurses. So that's what I was meaning by that. So what do we do? But it all comes down to money. It does. It truly does.
And do you think the community would be prepared and GMH would be prepared to focus on primary tenants? Do you think that's where we're at?
I don't want to say that. I honestly don't, because now you're talking philosophically, correct? So if I don't want to say that, madam. I don't. What I do want is I want a true discussion with all of us together. And really it has to be all of us together. I can ask for a lot, we can ask for a lot, but really it truly comes down to we are all a team with the island of Guam, with our people. That's what I'm saying.
Thank you. And I just want to congratulate to the coders for really closing that gap. I was clapping inside, so
Thank you. They
congratulations
really
on that.
worked hard, and it was amazing to watch the numbers drop every day. So they really put their all into it too, and the additional staff all helped too. So it was really a collaborative effort for all of them. Thank you.
Yeah, that's great. And how can we improve the reimbursement for Medicare, Medicaid? I know you said there's a cap, and I know in some states there's no cap when it comes to the total amount that a jurisdiction gets, but maybe I'm conflating different things. Can provide some information on that.
Yeah, thank you for that question as well. We need to really look at that. We're not like, we are not a value based on conditions or like diseases, right? Like in the States, they're under that realm. So like if somebody has congestive heart failure, they come in, there is a certain price tag for congestive heart failure given to the hospital for that diagnosis. And it's really truly up to the hospital on how they delineate and disperse that money within, right? We are not under that. We actually just get a pure rate. Well, a pure rate in surgical ward, we can meet it. But that same rate in the ICU, we're beyond it. We're losing money, truthfully. But so that's the fact of, even if we rebase it, that's what I want to get at. We still have an aged facility. We're never going to be able to command the rates that GRMC can, for example. We're never going to get up to that. Not with our facility the way it is. I am in total agreement that we need to maintain our facility. We have to maintain. We have to. And honestly, we're not. Can I just be transparent? And that's hard for me as a leader. But we need to get to that. And we are. And again, Yuka and I and Rodolin and Zaldi, we're all working on this. We're all trying to put in whatever we can, extra money to just get these things done. So, yeah.
Sorry, Senator. This is Jordan Pauloon. I'm the legal counsel. Just following up on your question, though, about rebasing and getting that. Even the question for us isn't a total amount of Medicaid or Medicare funding available to Guam as a whole. It's really about how much we can bill per individual patient. And no matter where we are, there's typically a cap on it, whether it's a diagnostic cap or a daily cap. And that's based on the how the rates are determined through like rebasing and all of those other things. There's never going to be a 100% reimbursement across the board in a hospital over something like that. That's how the federal regulations and structure set up on that, because they have the formulas for it that estimate it. The upside is when you do bill Medicare and Medicaid, they pay regularly. They just don't pay 100%.
This goes for any jurisdiction.
Yes. So some states and jurisdictions have like annual caps on the total amount of like Medicaid funding that the state has. Some don't. That's not really the question for us, because that's a whole island question. For us, it's really what the caps are on the individual claims or patient care that we have on an individual basis. I'm not really sure if there is a cap or what it is for Guam's Medicaid reimbursement overall, because Medicaid does run through public health, and there are some other costs and stuff associated with that. And it doesn't just cover payments to GMH, it also covers payments to other facilities for healthcare services.
Yeah, I know in the States, county hospitals tend to run in the red. So, I mean, this is a, I think, typical scenario. But have you studied those other county hospitals that may have, reached more of a, they're able to catch up on the expenses?
Yes, I have, actually. And the more of a positive thing for them is that there's another hospital just down the corner, or even 50 miles down the road, or things like that. What Guam Memorial Hospital is a little bit different, right? So, yes, but again, they're operating their Medicare rates under their jurisdiction different than in Guam is as a territory.
Okay. I think those are my questions for now. Thank you. Thank you so much for the presentation.
All right, thank you. Senator Tello, you can finish up now.
Thank you. Thank you for that little break, Mr. Chair. So I just wanted to go back to the billing and collections again. It's at so right now we're looking at only in collectibles 8 million versus billing, and you're saying that 36% of whatever is billed out to the public is what we're probably going to collect.
It's around 36% right now, yes.
But we're only talking, but then you said it's 100% regarding insurance.
Yeah, I'm talking generally, overall, when we do the calculations of our collection rate, it's about 36%, including the private insurance, and self-pay is also included in that percentage.
Private insurance, but we're still at 100% on that. So we kind of have to break it up, to address it. If we're not having problems with insurance companies, or even that percentage is lower, we should separate it from what the true uncollectibles of 36% or collectibles of only 36% on that. That's what we should be focusing on, and find the issue on how we can address that. We keep talking about Medicaid and just like the other senator mentioned, or how you brought up, it's like this in other jurisdictions. It's the same thing. but I don't know if they're in such a red like we are. And I was hoping you guys would come to us today, giving us a plan, a solution, on how to fix this. Because it's obvious we keep, sending money to you, and you come back with us later on saying, oh, we need an additional 30 million. Or we give you the 30 and you say, oh, we need additional 14 million because we still owe vendors 14 million. So what is it? It's just hard to look at this presentation here and try to see what's your plan and what are we going to do to help this. On the Medicaid, you said it's limited to 1,675, right?
Yes,
and the
that's
average
the
is 11,000.
per diem rate.
And the average of bills is actually 11,000, right? When it's
No, ma'am. Our per diem rate is 1,679 currently.
Oh, 9. Okay.
But the cost of, the way Medicare will calculate it is the cost of discharge. So right now, per discharge, they will reimburse us for $12,571.9, but our actual cost of discharge is much higher than that. It is actually 24,200. Yeah, there's such a very big gap between, and the gap has been nominal in the years prior to COVID. The gap had been annually about 2 million to 5 million versus the actual costs of the discharging the patient versus what Medicare will reimburse us. And then in 2020, that gap climbed to 11 million. And then in 2021, that gap climbed to almost 19 million. In 2022, it's another 18.5 million. And then in 2023, it's now 14.6. So it is coming down, but it's definitely a result of all the costs, the inflation. We're all feeling it with what happened as a result of the pandemic. And unfortunately, I thought things would go back to normal. We kind of thought, pandemic is over, we go back to normal, and we're clearly not seeing that. Inflation has stayed relatively high. The cost of goods for us, the cost of labor has been phenomenal. We've had to pay the nurses a lot more just to keep them. And we've had to hire a lot of travel nurses because our nurses are leaving and we have more COVID patients. And then there's the cost of physicians, to hire physicians now because, and a lot of it has to do with some kind of phenomenon during the pandemic where everybody just kind of refocused and said, I don't want to work anymore. So we did lose a lot of workforce, not just on Guam, but across the nation. Healthcare workers were just saying they don't want to do it anymore. They had burnt out. So our situation on Guam is really not very different from other states, where they're also using a lot of travel nurses, and we all can't afford it anymore. So what we're reading is they're also cutting services. They're only running an ER, they're only doing childbirths, those kind of things, because they just can't afford it anymore. Things are not gonna get normal to pre-pandemic.
And it's kind of odd because, we're seeing an exodus on this island,
We are.
About 155,000 in population versus before COVID, it was 175, I think.
Yes.
So with such an exodus happening, you would think, the population is going down, so, the cost for the hospital and everything else should be a little bit more minimal. Definitely, our tax base, though, it seems to stay stagnant, but I'm not seeing any of the, I just recently was at the hospital just 2 nights ago. A friend and son passed away, and it was late at night, and I went to the hallway. In fact, one of the kids that were with me says, "Oh, Auntie Teller was here when the water was falling down at the elevator, and it was all breaking down." You spend about 98 or 95% of your budget is on salaries. Is that true? And then on maintenance is how much?
Our budget for salaries for employees is actually around 65%.
65%, okay. Not sure why I came up with that 95% on salaries. So you spend on salaries, on the budget that you were given in FY24, 65% on salaries. How much on maintenance?
I do not have that exact percentage.
Oh, and that's why the rain was falling inside Guam Memorial Hospital. Don't even know the amount of money for maintenance? Oh, that's disappointing. I'm requesting for that, Mr. Chair, at least to have that figure so we can see exactly what you're spending on maintenance of the building. You talk about one of your options here, you know, and maintain that $30 million before a new hospital is built, and there's no maintenance incorporated in that. And we're seeing our current hospital, you know, break down a lot faster. It's going to be worse in a couple years, and we know that the hospital probably won't be built until 5 or 6 years from now. So every time that you've come in front of us, I've always asked for that maintenance cost. What are you going to do to keep our hospital afloat until a new hospital is built? So I really would like to know that, and I just think we need another hearing and maybe an oversight on the hospital and find out what your plan is. So moving forward on keeping that hospital safe for not just our patients, but the employees that work there. I really worry about them. Walking down the hallway, you're determining if that ceiling's going to fall on their head or not. Then you're going to have a real issue. So other than that, I'm just going to read through this. I'm probably going to call and ask for questions later on to try and absorb this. But I thank you, Mr. Chair, for the opportunity.
Thank you. Senator Fisher, you have any questions or comments for the panel?
Yes, thank you. Yes, thank you very much, Mr. Chair. Ms. Hechanova, my first question is to you. Had we asked the Guam Memorial Hospital Authority to assemble and bring today to this hearing the cost of maintenance at the hospital, the expenditures for maintenance, would you have been able to do that?
Yes, actually I had to just pull it out of the details in the budget, but we have about $2 million in our facilities budget for maintenance of our elevators, our chillers, our hoods, fire testing, our fleet, our boiler, our heater, our generator, grease trap, and biomedical equipment.
Okay. So the hospital does, in fact, track what you spend on maintenance?
Yes, sir. CMS requires us to keep our hospital in tip-top shape. So if we don't have these contracts, especially for like fire suppression and things like that, we are in a lot of trouble. So it's very important for us to keep on top of the maintenance.
Okay, I just wanted to clear up any impression that a person watching or listening might have that the Guam Memorial Hospital Authority does not, in fact, track maintenance. Of course it does. I mean, it's just absurd to assume that it wouldn't. I'd like to follow up on Senator Perez's question, and I suppose this could go to any of you who may have the expertise. I often have wondered whether or not, as to GMH, we are asking the correct question. It's perennial. We come in here and yell at you guys for the money, and you ask for money to operate the hospital, and we push back and so forth and so on. And that's been going on, I'm sure, since they turned dirt at that site. Now, I have never expected, and I don't think anyone ever has expected, the Guam Memorial Hospital Authority to turn a profit. Nobody would ever expect that. I've always thought of Guam Memorial Hospital as analogous to a county hospital serving a population that is largely uninsured, yet we must still render service to them. Now, GMHA has come in and asked for a certain amount of money, and you did the same last year and the year before. Are your requests different, radically so, from what you might find, I don't know, in a county hospital in Hoboken, New Jersey, or Milwaukee, or someplace else where they're serving a community of uninsured people?
I would think not, because if your patient population is the type that just cannot pay, there's no way you can keep operating without some kind of a subsidy.
Okay.
And that's exactly the situation that we're in here. We do have, I talked also in the presentation about some social cases where we have patients that are stuck in the hospital, they have nowhere to go. And so they're occupying our beds, and we are required to provide them medical care, even if they're not very sick, like somebody in the ICU.
So just to make it clear, so unlike a private hospital, you can't just stabilize somebody and then ship them on. Is that correct?
No, sir, we cannot.
You have to render treatment.
Yes.
And is it also true that you have, I think you just said it, you've got individuals occupying beds long-term that may be either underinsured or not insured at all?
Yes, that's correct.
And when that happens, which I'm sure is not infrequent, who ultimately must bear the cost for that? I assume it's the hospital and the taxpayers.
Yes.
Okay, and to me, that just seems to be one of the obligations of the community. Of course it is, to take care of the health of people. That's why we have county hospitals. And I mean, there's no way to turn away from that. That's an obligation we must meet. And I've got some more questions, but through my years of observation, it has never been my impression that the Guam Memorial Hospital Authority is padding the books or putting on ghost employees or just shoveling money out the door. I understand that the Guam Memorial Hospital Authority has had significant difficulties with the weathering and age and so forth like that, but I've never been under the impression that you were feathering your nest or rendering inadequate service just so you could pocket $1 or $2. I know that it is very difficult, there's no question about it, what you do in your mission, and I know it costs money. And it is my belief that we have to address overhead in government. Overhead in government includes provision of education, and it includes provision of health care and safety. So with that, I'm encouraged to hear that you think we are not that out of step with other hospitals or other hospitals that have to render service to populations similar to our own. And so I'm glad to hear that. Mr. Palun,
Yeah, I would just like to follow up on that a little bit, because I have both been a lawyer for and a patient of healthcare facilities in the mainland United States, both from big city facilities to small county facilities. And one of the things that's unique for, we're not that far out of step as it is from the county hospitals, but we also have something unique from the county hospitals, is that we don't have a big city hospital that we can transfer anybody to. So in order to get a lot of these services, if services were to be shut down on the island, whether it's with us or one of the private institutions, we're talking about sending people to the Philippines or to Hawaii or even to California to get the treatment that they otherwise could get here at home. And so that's that's actually a very geographic problem for us.
I think that's a very good point, because you don't have the economy of numbers. You can't spread out the cost of a machine that costs $1 million over 10,000 people. You may have a population that must have that machine, but it is not cost effective because there's simply not enough people to use it. Nevertheless, we have to provide the service. I think that, do I understand you?
Yeah, you understand my point, is that we have to provide that service, or we need to make arrangements for our residents and family members to go off island for them.
So,
and on top of it all, if you look at the geography, we are, in a large swath of the Pacific Ocean, the only full-service acute care facility. We're the only one that handles maternal child health, pediatrics, and all of these things for miles and miles around.
Yeah, and obviously you have to have the infrastructure to take care of that. And the costs of that are not infinitely elastic. There's only so many people on island. So anyway, I wanted to ask you a question about, I think it's this, I don't know how to identify it. It says up in the left, Guam Memorial Hospital Authority, and there's a summary by division. And I was wondering if you could help me understand what's going on. I'm looking at, if everybody's with me, I'm looking at column B, which is entitled Fiscal Year 2024 Authorized Level. And Ms. Yukonova, do you see what I'm saying, what I'm showing?
Yes.
Could you explain what that means, authorized level?
This was the amount that was appropriated to us in FY24.
By the legislature?
Yes.
And then right next to it in column C is something called FY 2025 Agency's Request. Could you tell us what that is?
This is the amount that we're requesting for the fiscal year 2025.
Okay. So do I understand that in 2024 the whole ballgame, what we authorized was $30,205,699?
Yes.
Does that include the $30 million that we subsequently gave you?
No.
Okay, so whether or not it was, well, I guess it was authorized. You received $60,205,699 and change or something?
Yes.
Okay. So the legislature, evidently, we might have had some heartburn about it, but I think we recognized our duty and did what we had to do. And this year, the agency's request is $74,298,141. Is that correct?
Yes.
So is it more accurate to say that if you get the entire request, that as compared to the actual outlay in 24, you are asking essentially for $14 million more?
Yes, that's correct, sir.
Okay, all right. So I just wanted to, I wanted to understand that. Now, Doc, as part of your presentation, you gave us some slides, and I wanted to ask you some questions about, I guess it would be your second slide, and I wonder if it's possible that we could allow the people at home to see the slide. It's entitled Fiscal Year 2025 Budget Request. Oh, there it is, that one. Okay, so yeah, the one thank you all. That's what I'm looking at. It says Fiscal Year 2025 Budget Request. The projected operating expense for the hospital is $232 million. Is that correct?
Yes.
But of all the money you're going to get, whether or not it would be from insurance companies, from the Department of Corrections, from taking care of inmates, federal government giving you some money, you're only going to get $157 million?
Yes.
And clearly, that's not going to be enough.
No.
And so there's a shortfall of $74.3 million.
Yes, that's correct.
Okay, so we need to come up, and then we need to come up with that $74.3 million. And fortunately, we don't have to come up with all of it because there's something called the Pharmaceutical Fund, which is going to kick in $23.4 million, right?
Yes. And if the Pharmaceutical Fund projection is higher, we could also get something extra from there too.
Okay, so that's good. When your budget request then is a total of $74.3 million, Pharmaceutical Fund plus General Fund.
Yes.
Which is about $14 million more than you got for all of last year.
Yes.
Okay. Could we go to the next slide, please? It's entitled Personnel Contractual Supplies Trend. Thank you very much. I see the top line is personnel. The blue line is personnel. The line in the middle is contractual expenses, and the yellow line at the bottom is supplies and materials. Personnel cost appears to be climbing, and I understand that. There's a labor shortage worldwide.
Yes.
And I would assume that a lot of this personnel cost went to things like traveling nurses and locust tenens,
No, sir.
whatever?
The traveling nurses will be under contractual. That blue line on the top with personnel is really our staff and employees. That is in-house.
Okay, and so we can all understand, I mean, it's clearly been climbing upward. Why is it climbing upward?
We have had 2 increases for the nurse pay plan in the last 2-3 years.
Approved by the legislature, I assume?
Yes,
Okay.
and we've had to institute higher differential pays for the nurses and even for the clinical technicians, those that operate.
Okay, what is differential? I'm
A
sorry.
differential is a working differential. So if the staff during working hours will receive, say, 15 or 20%, depending on what department they're in, We offer these incentives to retain them.
Okay.
We also had the general pay plan increase for the other employees as well, so that also caused a spike in the personnel costs.
Okay, and it looks like the contractual costs, which you just mentioned, have a slight climb to them over previous year's levels. Is that attributable to the need to bring in nurses from off-island and so forth?
Yes, absolutely. Yes.
Okay, and then you also, supplies and materials, we all know that the supply chains just basically froze right at the end of the COVID disaster. And they're still getting unscrewed, I'm sure. So does, here's a softball. Supplies and materials, is that because of supply chain problems and so forth?
Absolutely, yes.
Okay. And then if we could go to the next slide, it's entitled Fiscal Year 2024 Billing and Collections. It looked like at one point, well, first of all, we've got a green line running through it that says budget. Could you explain that? What do you mean by budget?
That is our target for collections every month. So if we bill approximately 25 to 30 million a month, we expect to collect about 11 million a month in cash receipts from these. So that is really just to gauge our target, so to speak, because we're trying to reach a target every month. I want the staff to realize that this is what we're trying to collect every month. So that's why we have the budget there of 11 million every month.
Okay, so is it fair to call that like a best guesstimate of what you will receive?
Yes, it is.
Okay, so, and then still on this chart, there was some controversy. And I don't know all the details, so I'm probably stepping in it here, but there was some controversy about the way, I think the hospital may have entered into a private contract or something to increase billings. Just, never mind the details, the background, the context of it, but just as a model, was that successful?
To some degree, yes, it was. Our collections for the year that we had the contract in place, the collections actually did go up higher. We were able to make a lot of changes in our revenue cycle departments as far as structure, reorganization, and even really defining what everybody needs to do. So it was a really good exercise of understanding what the revenue cycle is and how important it is to the hospital. But more importantly, it really brought everybody together. They knew who to report to, who they were accountable to, what their role was in the revenue cycle. Whereas before, they were very siloed. You know, the coders just did their thing, not realizing the impact of their work on, say, billing or coding, collections. So now everybody understands what they need to do, and it really truly is a cycle right now where everybody knows that what they do impacts other areas.
Okay, and I keep using this word collections like everybody understands what I mean, but I mean, this is a term of art in the medical community. Collections in a hospital, as I understand it, are actually difficult and require an amount of expertise to do it. It's not just necessarily sending a bill, is that correct?
No, because when a patient gets a bill, oftentimes they need help to understand it. Sometimes, there are charges on there for things like medical and drugs and things that they may not understand. So when they call our collections office about, I have this bill, what can I do about it? The person answering the phone has to be able to explain the whole billing process to them, as well as those items that are on their bill, so that they understand.
What about when we say billing, we're also including the idea of billing Medicaid, Medicare, and Netcare, and Stay Well, and St. Mary's, and the rest of them, right?
Yes, they're all considered payers. Yes.
Okay, so I assume that they have certain requirements in reporting, and if you don't meet those requirements, they're going to kick it back.
That's called a rejection, yes. So we have a clearinghouse where all the claims have to go through, and those claims are vetted through that clearinghouse. So if the wrong code is in the wrong box, or the physician name is wrong or something, it will reject it, and it has to be worked on before it will pass through the clearinghouse and actually get transmitted.
And does the hospital have a time limit on that?
We have 90 days to bill for private insurance and 1 year for Medicare and Medicaid.
And what happens if you don't meet the 90 days or the 1 year for Medicaid?
They
Medicare?
claim, we will likely still bill it, but we'll wait for the denial to come back, and the denial will be for untimely filing. That is the name of the denial.
Okay, so I'll just wrap up this section of the questions. And would you ever consider returning to a model that privatized the billing?
At this point, no.
Okay.
I think we do a pretty good job. A lot of it has to do with good leadership. If you have a good leader in place to lead the team and to give them direction and guidance and monitor their progress on what they're doing, they can get a lot done. And a good leader also motivates the staff. I think we were missing a lot of those elements maybe in the past, where there could have been a low motivation, or just if you don't understand why you're doing what you're doing, you're not going to do a very good job of it. But right now, the staff have been very dedicated to the work that they do, and they're really working very hard to make sure that when we come before you in the legislature, that you can see the progress that we're making. That's what they want to do.
Okay, and that being the case, and it sounds like you are satisfied at this point with what's going on, the direction you're headed, I'm glad to hear that. And maybe you would extend the legislature's congratulations and thanks to the leader and the staff of the team doing that.
I will do that. Thank you very much.
Okay, thank you. And then I have another question on the accounts payable as of May 17th, 2024, which is the next slide. Yeah. There we go. And I'd like to, there's just one question on this. If we look at the column of over 90, that would mean that some of these accounts receivable, or these are accounts payable. Some of these accounts payable are aging.
Yes.
Yes. Do you follow kind of a first in, first out FIFO? You know, the first bill you get is the first one you pay?
Yes.
How do you, this accumulation of $8 million in accounts payable, I mean, I'm sure that represents many different accounts, but I'm wondering how that occurs.
If we don't pay the bill within the invoice date of with 90 days and over, they will automatically age in our system.
Okay.
Because we have to put in an invoice date, and so it'll automatically age and drop it into the correct bucket.
So could it be aging due to factors such as, I don't know, an improper invoice given to you or something along those lines?
It's aging because we haven't paid. We have no cash. It's a cash flow issue.
So this is just because you don't have cash?
Yes, these are real invoices.
Okay, I see. And then, if I could, I would like to, it might be the last one. Oh, the accounts receivable, which is the next page. May 17th, 2024. Accounts receivable over 360 days are $218 million and 497,000 and change. Is that correct?
This is actually, the over 360 is only for the self-pay and the government. For the private insurance, we put it in the over 90-day bucket, because if those are over 90 days, there could be some issues with those claims that we need to get resolved right away.
Okay, and when we say self-insured, we mean people literally who do not have health insurance.
Yes.
They're self-paying,
Yes.
Which is a huge portion of
Yes.
our population. Of the $218 million, how much of that do you think is owed to you by the government of Guam?
It is actually, it says here 5.8, but this also includes about 1 million from the CNMI government. So it's probably around 4 million.
Okay, so we're talking maybe 2% of the whole amount.
Yes.
Yeah. As to the other 98%, are you optimistic, not optimistic, cautiously optimistic that you'll ever see that money?
Not the self-pay.
Okay,
Yeah,
so
not the self-pay. As far as the other payers, we're working really hard to get those collected. There may be a small portion that we will not collect because of denials or whatever reasons, but we're currently working on those. But the self-pay of $205.2 million, It's very difficult to see how we're going to collect all of that.
Okay, is there any possibility of selling those accounts?
We have been thinking about that.
Yeah.
We have. Right now, we're just analyzing the entire 205 million. A portion of that is actually with DRT for garnishment.
Yeah.
Another portion, I believe, the patients have already declared bankruptcy, and so those will be written off. And there's these other classifications that we're putting this 205 million in, so we can come to a number of how much we actually want to possibly sell, if we can legally, or give to a collection agent that we would hire that will give them a year or so to collect and then eventually write it off if it's not possible to collect.
You know your business well more than I do, but you're going to get like 5 cents on the dollar.
Yes, we know, but we need to make an effort as much as possible. So we want to make that due diligence and try to collect it. Sometimes we don't even have the right patient information. The phone number's wrong, the address is wrong.
They're gone.
There's no phone, they're not
dead,
alive
who knows?
anymore. There's a lot of issues, but we're vetting all of that now to see what we can do.
Okay, and then thank you, Mr. Speaker, or Mr. Chair, for giving me that. I cannot agree that you have not come forward to us with solutions to the problems. You have given us options, and you have told us quite clearly if we don't pay for it, we're not going to get it. And that's just the way it is. I mean, our healthcare budget could be zero if we just decided not to give anybody any health care. It's just not going to happen. And you guys, the way I look at it, sir, is you've given us options and told us, well, if you want to pay for this, you know, if you want the Cadillac, you're going to get that. But if you're going to go for the Volkswagen, you're only going to get this. So, I mean, that's the way I'm looking at it. But anyway, Mr. Chair, thanks a lot. Then thank you all for answering the questions.
Volkswagen's more expensive nowadays, but anyway. I'd like to also I'd like to recognize Senator Blas for joining us this afternoon. Senator Brown, do you have any questions or comments for the panel?
Thank you, Mr. Chair. I'm still trying to figure it all out here. I'm on the wrong side of the table. I got to change my profession. I got to go back and run a department where I can come back and say, well, if you don't do this for us, we're not going to operate, and get paid, 6+ figures. I don't know. I've just been at this too long, maybe, because you did mention that your administrator will be back soon. How long has she been gone? Because lately, she's not appeared before us here at the Guam legislature.
She has been gone since March 15 and will be coming back at the end of the month.
Okay. Well, it's good to know, because I'd like to know who's actually representing the administration, because we were promised better health care, and yet I hear the same old story, and now the amount has grown by $40+ million. The administration's not requesting that amount of money. Why are they not requesting that for you?
I can only speak for ourselves and our hospital, and everything I am being as transparent as I can with what we have today.
I understand. You're not in a position, that's the problem. You're not in a position to represent the administration. Ms. Posadas is, and she's not here. I don't know that the revenue stream, while we have declining populations, are going to continue to be able to accommodate the growth to the level. And I'm not in charge of making decisions at the hospital. I don't know that the most efficient decisions are being made. I don't know if your staffing pattern's right up. I don't know the last time you had a full assessment of your operations. I mean, there are a whole lot of factors that could be going into the figures before us, but to simply say, well, this is it. If you don't do it, that's your problem. That's not taking responsibility. We all know there are challenges affecting the hospital. We understand there are patients that are going to come in and get service that are not going to pay. I mean, there's nothing new with that. There's no revelation there. But with regards to things like I want to ask that came up, that was an issue this past year, was your patient tracking system. What's the status of that? Because we were told publicly that the system doesn't work effectively, or the system was not designed for a hospital. Is that the case?
Senator, do you mean the EHR? Is that what you mean?
Yeah,
okay.
Whatever you call it.
I'm sorry.
If that's the best terminology, EHR, then I'll call it the EHR.
Okay. So the electronic health record, what we have is what we have, truthfully. And from my standpoint, it is the infrastructure of our technology that we need to work on, meaning that we could actually get the Cadillac, which is some bigger systems that are better and the best and everything. But if we don't have our technology infrastructure at the hospital itself, it doesn't matter. It's like we have the car, but we don't have the engine. So from my standpoint, the best use of our money is to work on our technology infrastructure, which is what is going on presently with more access points so that the Wi-Fi works and things like that in the hospital for a very, very brief example, and to actually work with what we have for the electronic health record that we have today. That is the most prudent with what we have.
The system is not that old, is it? How long has it been since it, I mean, this is interesting. How long has it been since it was acquired, and who made the decision to acquire it if it's not going to properly work to the needs of the hospital?
The system we have since 2022 in October is when we started the system. And so you are absolutely correct. It is not that old. It's actually very new. And so we need to work within the framework of it today.
And how much was spent on this system?
How much was spent on the system? I do not have those exact figures. I know that they have been presented. I just don't have them in front of me today.
Does your accountant know how much was spent on that system?
I think it was about 4 million. If I could be mistaken, but that was the last I remember was about 4 million. So that includes all of the licensing fees that we pay every month. There were some other peripherals that were purchased. Those are the ones I'm not sure about, but I know that we pay the licensing fees every month of about $200,000 a month.
Well, I mean, the feedback we got is that it's not working to the level of expectation, because this was promised as, you know, once we got this in place, it was going to help facilitate our patient records and make it more easy to operate, and that's not the case. I'm just giving you that as an example. And the public out there that's listening, when things like this happen and we don't have the level of efficiency or we don't get what we think we're buying, yeah, measly $4 million. Wow, to most people, that's an astronomical amount of money. And I don't know if this particular system can be upgraded. I don't know who procured it. I don't know who's held responsible for it not performing to the level of expectation that the hospital, maybe not yourself in your acting capacity, but the hospital had promised the public that they were going to receive as a result of this system. Those are the kind of inefficiencies that we see of money that is concerning, because it's such a big operation. It's like, you know, education. It's got such a big umbrella. When you start getting into the details, then you start really wondering where in certain areas are monies most effectively being spent, or are things being properly acquired? And then at the end of the day, who's held responsible when it doesn't work? I also want to ask, what additional funding is the administration providing? Because again, their request is really, you know, their request and the request of the hospital, you know, there's such a big difference, such a big, huge gap. You're coming to us, I mean, the governor's sitting on still I think a couple $100 million left from ARP funding. The clock is ticking. We're what, in May? Another 6-7 months? I understand that's when it's going to expire, unless something's changed. I'd be investing it in healthcare at this point, because I don't know what else the governor's going to be able to spend it on.
Thank you, Senator. Yes, I deeply understand where you are coming from. I do. And we are, what is with the ARPA funds is at her privy. What to us is we are the caretakers and stewards of the money that we are given to run the hospital. And it is not, I do have sleepless nights, even as the acting administrator, because I keep thinking of inefficiencies. And anybody can attest that's beside me and behind me that I come to everybody each and every day with things that we need to keep working on. We need to change this, we need to change that. And you're absolutely right. I am humbled by that, and I understand where you're coming from. And none of that goes beneath me. I am deeply trying to figure out these things, and I'm deeply trying to actually bring things up for the administration that will be left when I'm not here. And that is my job, that I have to do that.
Well, I just think it needs to be brought to light, because if we can't come, which we haven't been able to with the administration, where to locate a new hospital, and the clock is ticking. I mean, if they can go out and reevaluate property with that money, which was intended for health-related issues from the pandemic, I don't see any reason why more of that money can't be invested to address some of these infrastructure needs at the hospital, to offset the expectation that the general fund is going to be able to accommodate, because the party's going to be over at some point soon. I mean, the university came in, what, $17 million increase? I don't know what world we live in if we think that, oh, no problem, we're just going to ask for that amount as if it's sitting in the bank account and we'll just hand it over. I just can't see the phenomenal growth of government at that rate while we have the tax-paying base of this island leaving. It doesn't add up, at least not for my side of the aisle. But I'll tell you, I'm going to aspire for your job on that side, because that's easy. I don't have to account for my performance. I'm not talking to you in particular, because your time as acting is very short. But certainly for the administrator that has been there now going on 6 years, and the promises that were made to the public, and here we are. Like I said, anybody could be running the hospital. Anybody could be governor right now running GMH. Nothing's new, nothing's different with regards to the overall operations of the hospital, at least not from the outside perspective. And that's not for you to carry. You're just temporary. Thank goodness for you, you're just temporary. But I just think these realities need to be brought to light when you call people on things they say. It's easy to talk. Doing, obviously, is a very different reality, and I still see a challenge because the administration is not asking for more money. That's the reality. And can the budget chair here fork over another 40+ million this year? I guess we'll see. And if not, really, you're going to have to, and maybe not you in particular, but Ms. Posadas-Son's going to have to figure out how she's going to keep the hospital operating. And I don't know how they're going to get additional 40 million, Mr. Chair. Pretty soon we're not going to be able to extend the power credit. We might squeeze through this one more session, maybe, but that's about it. The ride's almost over. So it's just a reality check. I'm just dumbfounded by the continued presentation of coming here and somehow saying, this is your problem, and otherwise we can't manage the hospital. We can't manage this department or that department. And I speak because I've sat on your side. And I just expect more than just somehow giving us the problem. I think you should tell us what we're going to get or what we're not going to get, especially self-pay. Self-pay is such a small percentage. It's not the largest portion of your revenue stream. And yet somehow you're telling us it's impacting to such a degree that you need another $40+ million. I wish money was falling from the sky, but this island doesn't generate at that level. Will not continue to sustain at that level. So it's just a reality check for us that we have to deal with, and it's something you need to be mindful collectively in moving forward. I don't have any other questions at this point, Mr. Chairman. Thank you.
Thank you, Senator Brown. Senator Blas, do you have any questions or comments for the panel?
Thank you, Mr. Chair, and thank you for the panel, for being here. Mr. Prince, I appreciate your candor, and I know it's kind of glad that you're not the face of the administration, and you'll be able to give us, the forthright, what you feel is going to be necessary. I don't see any muzzle on on you for that, and I appreciate that. I notice, though, your 14 font presentation. Okay. One of the things that I was looking here is, it's kind of interesting because I will be nice, Senator Fisher, don't worry about it. I'm always nice to them. Just last night, I had to finish, as part of my continuing education requirement for insurance, I had to do a whole lesson class on Medicare and Medicaid. And I noticed here it was page 5, changes to reimbursement and payment models, including declines in Medicare and Medicaid reimbursement. Can you expound on that?
Yes, sir. Senator, what that means is nationally, what's going on right now within the jurisdictions, that because Medicare and Medicaid are undergoing different, going to a value-based system, in the national realm, it's declines. So right now, in what they do with the Congress is they actually say that the rate stays the same, or it may increase a little bit, but the declines is really in relation to inflationary costs and things like that. It's not keeping up with all of that. in regards to that. So that's what I'm just saying, declines. Thank you for calling me out on that. I need to hear that, but it's actually truly based on inflationary rates and what it is today.
Okay, with regard to Medicare, I can understand as far as the Medicaid because it's primarily
State.
It's more indigent type program, but with Medicare and the different parts for Medicare, what is our tougher rate right now? Where are we at?
We get $16.79 a day right now.
What does CNMI get? Do you know?
I think they get 2,000. We met with them about a few months ago, and I think they said it was 2,000.
2,000.
Yeah.
Why? Okay, they get 2,000, we get 1,600. Why?
I'm not sure when what their costs are based on, what year. I don't have any idea. They did share the rate because I asked them what their rate was, so they shared it. But the whole cost reporting and how far back they go, I don't know.
What's your aging as far as Medicare?
Our aging for Medicare is 1 year.
1 year. So where are we at right now? Well, how much do we bill and how much do we get paid so far?
I can give you that. You want to know how much we have billed Medicare?
Right.
So far for this year, we've billed about $55 million.
How much do we?
Medicare, what we have collected this year is $16 million,
55.
which is about 30%.
Okay, so let's do some DI math here. 55 minus 16 is what?
Yeah.
39?
That is 30% of what we have billed this year.
Yeah, but what's the difference, 59 and 16?
The actual difference? Let's see. So we billed 55, and we collected oh my goodness, 16, so 39?
39. And then you mentioned earlier, Ms. Sechenova, that with your insurance, how much have you billed and how much are you paying? I mean, how much have you been paying?
So for the private insurance, I'll give you the billing first. We have billed $52.2 million.
52, how much have you collected so far?
And we have collected $36.
So 52 minus 36 is
16.
16? And your self-pay?
Okay.
How much have you billed? How much have you billed?
Self-pay so far is about 30 million for this year, and we've collected 6 million. A lot of the collections from self-pay come from garnishment.
Okay.
Yeah.
39, 6, 4, 19, cap the 1, 6, 5, 6, $79 million. And you're asking for how much more an increase?
An additional 42.
42. And just for this year, you have $79 million in.
Yes, sir.
See what I'm getting at? I'm trying to figure out how we can close this gap here. Because I have to agree with Senator Brown and some of the concerns of some of my colleagues up here. As much as I know that we'd like to be able to do this, you know, the pie is only so big and you can only cut so much. Okay? And you know, just looking at these costs, or these numbers that have been unreimbursed or uncollectible or can't be collected, you know, how can we close that gap? so that it doesn't become something that's becoming reliant. You know, I mean, you mentioned in your report here, Jordan, you had something to say?
I was just going to say, when it comes to talking about billable amounts and closing the gap, some of the gap we won't ever be able to close due to how the economics of it work and how the legalities of it work. Take even the private insurance companies, for example.
I understand, but Jordan, this is a two-way street here. I mean,
but even the private insurance companies, for example, we're never going to close all of that gap because there are some non-covered benefits. There's negotiated rates for certain services that there's always going to be a gap. So starting from just the billable amount and looking at that gap is not going to actually give us the answer that we need in order to solve all of this. It is a helpful number, but just comparing to the billables, we have to recognize that we're always going to get less than the billable amount.
So this amount, let's talk about the insurance amount. This is inclusive, or this takes into consideration the negotiated amount, or is this the full amount that you decide to go and say you can't collect?
That's the full amount.
So the full amount can be $2,000, but your negotiated rate can be $1,500. The insurance company will pay the $1,500, and you say, oh my God, we're short $500.
No, the insurance are required to pay us 100%. We don't have any negotiated rates with our payers.
So who you have a negotiated rate with?
Medicare?
Yeah, Medicare will have the negotiated rates, and with the private insurance companies, the negotiated rates are typically with the businesses that they have the policies with, and that will be a maximum on the coverage benefit. And so sometimes they will pay us 100% of certain things, but there will be a cap on the amount of payment for specific types of things, and the rest would then would be allocated into patient responsibility.
So this amount then would then consider the negotiated rate, or is this the full amount?
You're talking about the billed amount?
Yeah.
That's the full amount.
Not the negotiated amount.
No, sir.
Yeah, but you made the negotiation, we did it, and now I have to make up the difference.
We didn't make the negotiations on those with the private.
The negotiation is two people.
But the negotiations on the private insurance happen between the business or individual purchasing the insurance and the insurance company, and that's why it gets reassigned to patient responsibility.
So where does that patient responsibility, how does that fall under? Self-pay or what?
Yes, once we get the explanation of benefits from the payer after we bill them, they'll usually indicate the amount that will fall to the patient, and then it will drop to the self-pay
So how much
side.
of this $6 million or $30 million that you build is from the self-pay?
Most of that is actually truly self-pay patients.
Okay. You're not able to delineate or to separate out which one was the negotiated rate? No,
Not right now.
not right now? Okay. How many beds do you have operating right now? How many beds do you have?
Right now, we have 110 operating right now.
Out of how many total beds do you
161.
What's your ratio as far as the number of personnel per bed? You have about 1,300 employees. What's your ratio?
In regards to nursing care, is that, can
Yeah,
you
I'm
please?
talking from the hospital standpoint, from management of the hospital. What is the ratio of number of employees per bed?
We can get you that number, sir.
Huh?
Are you asking per?
Not per
not
nurse, per
it's just
employee.
in general?
General.
Oh, okay.
Because then my next question is per nurse, because, you know, the poor nurses, a lot of times we
We have 7.6 FTEs per bed.
7.6 FTEs
That's the last calculation I
at
have.
110 beds or 160?
No, this is actually based on, because I think Dr. Prince is talking about how many staff beds we have. For our calculations, we have it based on our 160 beds that we have.
So at 160 beds, you have 7.1.
7.6?
At 160, 110, I'm sorry, 110 beds? 160?
Oh, okay, it is 133 beds.
133
Adjusted
beds.
occupied beds.
So you have 103, so the 7.6 ratio is for 133 beds.
Yes.
And how many beds do you have occupied right now? 110?
Correct, 110 in our acute care facility, but that's not including the skilled nursing facility, which would then be at 133.
Okay, so you have 23 beds that are not occupied, 7.6. That comes up to almost 70 employees. Right?
Yeah, currently today, 146, sorry. 146 includes the skilled nursing facility, which has a total of, of 16. So 146 minus 16 would be 130, and so we have 130 beds occupied, correct?
You have 130 beds occupied.
Correct, today, as of today.
Okay, that's 7.6 employees per bed.
At the 133 level that we had on average for this budget year correctly right now.
What's the hospital average of number of employees per bed nationwide? National average?
Great question, I do not know.
Pardon?
I do not know that number, sir.
It's 5.2. Anyways. Last question. Well, two more questions. One is, and I see Rodella in the back, and maybe because I asked her specifically this question. Labor and delivery, the aircons, and they said that we were waiting for the permitting for the electrical. Did you get an update on that? Because you say here May 31st you're going to have, everything's going to be up.
Hi, good afternoon, Senator Rodalyn Gerardo, Deputy Assistant Administrator of Operations. So to answer your question, yes, for the OB power source,
Yeah.
OB and LND and all of that, the vendor is still currently on site. They're still working on it, and they're still on track to complete that project
So
by May 31st.
So they did get the permit.
Yes.
Okay, because the last time we talked, they said that they're waiting for the permit. Then I called DPW, and they said they had the permit since March.
No, the permit was given, and then they've been working on it.
They received the permit since March. That's according to DPW.
Yeah,
Okay.
that's correct, sir.
Okay, I didn't want you nor DPW to be blamed because the vendor didn't have the parts and just didn't want to put it together.
No, sir, they've been actively working. We see them every day.
Okay.
Thank you.
Last question. You know, whether this $42 million subsidy or $30 million, which one is it? $30 million, $42 million? Which one is it that you're asking for?
42 additional?
$42 million subsidy. Let me ask you something theoretically. If you had to have a new hospital right now, would you still be asking for $42 million?
Can you repeat that?
If you were to have a new hospital right now or a new medical complex, would you still be asking for $42 million in subsidy?
That would be a complicated answer because at that time, we could actually probably rebase better. Because now we have a newer facility, we may be able to capture a higher rate for Medicare. It may be 42, it may be less. And again, it all also depends on, until that time comes, like I said before, we may need to relook at services and things like that, so it may be less or more.
So it's kind of interesting. So then, if you were to be able to make those necessary repairs and get those things back up in order, or things back in order in the facility, you may not necessarily need the $42 million.
Yes.
Yeah.
Yes.
Thought so. Which is why we've been pushing the governor. I says, look, we may not have the $42 million in this budget, but I know where she's got $200 million in another budget to be able to help you with that. And possibly part of that amount could be used to be able to help you capture a little bit more of the money that you're not able to capture in the amount of about $79 million annually, which will cover your $42 million gap. Okay? I'm trying to find different ways to be able to do this. Okay? So that, but this conversation doesn't end here based on just this budget. There is another budget that we can hopefully, we can request, because that's the best we can do. We can only request that it be utilized. But I'm in this discussion right now, that's probably the best use of its money so that you can get you guys back up on track. And you don't have to worry about it. The great thing about that money as opposed to this money, that money can be given to you right now. This money, you're going to have to wait and get it allocated throughout the year. Okay.
When it does come to the ARPA funds, though, there are some specific restrictions on it that they can't just be used to replace our general operating expenses, that, unless it needs to be something that is identified as above and beyond or within one of the specified
Sure, Jordan,
purposes.
but I think that we saw, and as far as the latitude, some of the spending has been, I purposely gave you guys a copy of that report the last time we met to show you how much latitude was given in different areas. Okay, so as much as I appreciate you bringing up that as an argument, that's just an argument. It's not a reason. It's more of an excuse than a reason. Not your fault. Don't worry about it. Okay, thanks a lot, Mr. Chair.
Thank you, Senator Blas. Madam Speaker.
Thank you, Mr. Chair. And thank you to GMH. Dr. Prince, as the acting CEO, thank you for your presentation today and your work for the months that you have been acting. It's not just this last term, a couple months, but I think there have been other instances as well, so thank you for that. And of course to all of your team for all the work that you're doing. So this is I guess a harsh reality, we could say, or also it also comes with a lot of questions, of course. I think, first of all, I just want to get the big picture right. And the big picture to me is that what you want from the taxpayers of Guam is $74 million. That would come in the form of pharmaceutical fund and general fund. And the pharmaceutical fund comes from the business privilege taxes. So it's all taxpayer money, $74 million. Some of the time, people say, oh, the problem with GMH is we have to take care of patients, all patients, but yes, and we have been doing that for decades, and we have not ever looked back from that goal, right? We've tried to find ways to make sure that they're all covered by Medicaid, or we even, the government, this is the thing. I don't think the model, that we're going to cover people, we've been doing that. We've been doing it with the general fund, with the pharmaceutical dedication of this BPT. And we have been taking care of the indigent patients, and we've been trying, I think we've been doing a much better job of getting them covered by other sources, such as Medicaid, federal sources. But the taxpayers have covered the MIP. MIP is paid by taxpayers. Anything that Medicaid doesn't cover has been paid by taxpayers. Anything that Medicare doesn't want to reimburse, in other words, taxpayers have also been subsidizing Medicare patients on Guam for all the costs that Medicare will not reimburse for Guam. And that, I feel, it's a big problem. And I know you're saying maybe we shouldn't even pursue the rebasement at this point and wait till we build a new hospital because of just the work that's involved. It takes years, and the amount that we're going to get back is only going to be 2018 rates, even at that. But yeah, it's very clear, the taxpayers of Guam are subsidizing that. We're subsidizing any non-covered claims for private insurance, right? So even if we have private insurance on our island, and whatever they decide they are not covering, taxpayers of Guam are subsidizing that at GMH. And of course, we're paying our government of Guam insurance. So when you say, or you know, when some people say the taxpayers are not doing enough for GMH, I really think we have to be, you know, just sensitive about saying that, because I actually feel very defensive about it. Like, that's so not correct. We have paid so much for GMH for health care on Guam all across the board. So this proposal that we're going to cut some services because we can't put up enough money, you know, I appreciate you bringing that before us, but I think we have to, of course, I think the taxpayers would ask that we make sure that, are we spending the right amount of money? Are we collecting the right amount of money? So I appreciate my colleagues questioning about the collections. It really is kind of baffling, right? So if you could just remind us, Ms. Hechanova, the reimbursement of private insurance, you said you bill them 100%. There's no discounted, negotiated rates. Do they get prompt payment discounts?
No.
None. All right. So what they are billed versus what self-paid are billed same?
Yes.
Okay. And then the reimbursement of Medicaid, Medicaid pays whatever you bill them?
Yes.
And MIP?
MIP also, it's very small, the amount of MIP. It's really negligible that we don't even really...
You mean we don't have that many MIP patients?
Yes.
Well, that's been the government's goal. So we've tried to transfer everyone over to Medicaid,
Yes.
which we used to just pay straight out under what we called MIP, but was strictly general fund money. But now we've done a much better job.
Yes.
Public Health's done a great job transferring people to Medicaid, and so that has helped us a lot. Mm-hmm. In the past, there were presentations about the billing talking about unable to bill because we were too late, the system had shut down, the EHR wasn't compatible, many things, and we have written off quite a bit of collectibles. Is that, I guess that's in addition to those that you show here as receivable?
We haven't written off anything based on what happened with the EHR. They're still sitting in our receivables. We're trying to do whatever we can to bill them, and we have. As a matter of fact, during that time, we did negotiate with the payers for a discount because we couldn't provide the medical records, and they require medical records to accompany the claim. And so we're like, well, we can't produce the medical record because the printer's not working, we can't get access to the system, and so we did provide them a discount so we can at least get those claims paid for some percentage.
All right, but you've been announcing in the meetings some write-offs. What are those?
Those are for this is part of our project to clean up the AR. So we have, the AR has always been a monster. There's accounts in there going all the way back to the 1990s, and we don't know why these claims are still there. So we're really taking a better look at what we can write off, because the chances of collecting it are just, it's never going to happen. So we are compiling this list, and every month we take it to the board for their approval, and we discuss what the issues were with these particular write-offs, how we can improve our process better so that it doesn't happen again. That's the process that we're doing right now to write off very old claims. Some of them, yes, were the result of us not billing on time. We lost those claims because for some reason we did not bill on time, and there were...
In FY24, did you lose?
I'm sure we did.
Yes.
Yes.
I thought you made a presentation to us
There
about
are a
that.
few times where we just can't make the bill for whatever reason. We either lack documentation. Sometimes we really just miss it. It's just something that we miss.
Didn't you estimate in the last budget hearing that you would bill $100 million or more?
I can't recall, but we bill a lot more than that.
Oh, sorry.
Yeah.
Then I thought it was a larger increase that you were going to take care of by billing. I guess, well, what I want to know is, can we break down this self-pay? I guess some of my colleagues also asked this, but self-pay, I think, needs to be broken down. Self-pay, you're including those that are just not covered by private insurance. You're including all of those that, do we bill them for the unreimbursable Medicare portions or not?
No, we're not allowed to.
Okay, good. And these are also including, it should not include any Medicaid, well, yes, uncovered expenses for otherwise Medicaid patients.
If
right?
something is not covered, but I believe for Medicaid, they cover everything.
Okay.
Medicare, there may be a few non-covered benefits, or the patient has a copay or a deductible, then that would be their share.
Because I'm trying to get an idea of who are these self-pay patients, if we're saying we're covering the indigent under Medicaid or MIP. So who are these self-paid non-collectibles? These are, I remember not too long ago, maybe 3 years ago, talking with Lillian and the Attorney General at that time about the collections, and they said, oh, it's going great. We were using the Attorney General at that time, and they kept saying we are doing very great, except for like the one large, litigation that you had with one private insurance company. But other than that, this was not the issue back then. I mean, of course, there's always unpaid self-pay, but it wasn't, I don't know. It was never presented as the monster that it's being presented today. And so that's why I'm just wondering, what would you say are the bulk of these?
You're talking about the self-pay?
Yes.
So the self-pay,
These people that are just
mention-
refusing to pay for health insurance, coming into the hospital and then refusing to pay their bills?
So the ones in the old bucket, that 205 million, that's in the over 1 year,
Yeah.
that really is a composition of many, many, many things. There are even some patients that have declared bankruptcy that we need to address and write off if we're not able to collect that. There are some that are truly self-pay that were never applied for Medicaid probably. We didn't have a very robust program as we do right now. We really want everybody to have some kind of coverage because that's for our benefit as well as the patient.
So now the self-pay is about 2.3 million? What does in-house mean?
That means they're in the hospital right now.
Oh, sorry. So what would you say, like, for our current self-pay? Or, if you get rid of those far-out cases that you're describing, what is our normal amount of self-pay that you are expecting? Yes.
It's really not that high because we really do try to get them on Medicaid. However, when the patient initially presents, they may not have Medicaid. There is a process that they have to follow.
Yes.
There's a lot of forms to fill out. They need a birth certificate and all this documentation that it takes so much time to get. So initially, when they're registered with the hospital, they are coming in as self-pay. And then later on, as we keep checking on the Medicaid portal whether or not the patient was approved for Medicaid, that's when we will switch the financial class from self-pay to Medicaid. So it will not immediately happen, but sometimes they walk in and they really don't have any coverage.
All right. Well, on your pie chart, it looks like at the most self-pay is about $15 million,
Yes.
right? So some of that should be collectible, right?
Yes.
And a lot of that should be collectible, actually, right? Is there any reason, well, you do have active collections, right?
Yes.
All right.
Yes. And they really focus mostly on the current account, so when the
Yes.
patient's been it's just easier to
Yeah,
follow up on those.
Definitely. Okay. So then back to the big picture. So in FY24, the appropriation was 30 million plus another 30 million supplemental after the system crashed and we could not pay our vendors. We could not send out bills. FY25, the governor's requesting 31 million. The agency is requesting 74 million of taxpayers' dollars. And then, Dr. Prince, you said that the governor is aligned with your plans here and your presentation to us and your options, I suppose. Yet her budget submission does not look like that at all, like she's in line. It's the opposite. It's 31 million versus 74 million that you're requesting. And it's only a $1 million increase over last year's appropriation. And has she promised you any, or have you discussed with her any additional ARP funds?
I have actually spoken with her, and I am in communication with Director Byrne as well as Lester Carlson as well, BBMR, and I continue to ask. I continue to do all I can.
All right, thank
honestly.
you. So the governor, by executive order, when we said there was a crisis at GMH and we had to put 30 million of general fund money, 20 million ARP fund money after the regular budget, the governor, by executive order, created this fiscal team. Has they come up with any other recommendations as to what you're going to do with this request for 74 million versus cutting services?
Yes, ma'am. We've actually did like a whiteboard exercise, and again, it goes back to how much can we truly collect? What can we expect realistically, and then working in from there. So that is why I am in, again, communication, even like with expanding public health in a way, maybe bringing outpatient services within public health, and just trying to see what we can do to avail to the grants, more federal grants, things like that. And so we're.
So are they have no other proposal other than what you're proposing today? That we have these three options?
Yes and no, I guess. No, but you're right. Yes, there are other options. I am deeply excited that our operations team is working with that 20 million ARPA funds. That's actually going to be obligated for sure by December, which is key, and you have the list there. I honestly think there is a work in progress. I don't think it's like cut and dry down, we're done now, and it's just, again, it's just staying in active communication and
I'm just asking about the fiscal team. The fiscal team that was appointed by executive order for GMH, if they have any other options put on the table.
As of this,
we have seen none.
As of this time, no.
Okay, thank you. So I thank you for your, at least your ideas in this. Part of the team is DOA. I'm not sure BBMR, but I know DOA was part of it. BBMR also. So I guess it's also perplexing to me that we've had many bills for appropriations come through lately, and not one of those fiscal notes mentions that GMH needs $74 million or 42 million more than last year or anything like that. And none of them who submitted the executive branch budget request to the legislature, where they allocate for the entire government of Guam and allocated for GMH 31 million, none of them has said in a hearing, in a letter, in anything that we need to revise our allocation of the general fund for the entire government of Guam in order to cover the 74 million that GMH needs. That's also perplexing to me. When we say we're on the same page, it doesn't show like that in anything that we have in front of us, except you saying that to us. So I'm just trying to, I guess, impress upon you that if this is urgent, it's not looking like it, because it's looking like to the executive branch status quo. To the executive branch, Like I said, they haven't suggested to revise the executive branch budget or any of, the fiscal notes that are coming in, or nothing has come down regarding GMH. Not even from that executive order task force that they put in place specifically for this purpose. No additional ARP funds either. So the three options, whose decision do you think it will be? Let's say, you get less than 74 million from the general fund this year, and you gave us an option that what if you only got 30 million? So you said, option one, you need 60 to 80, or the 74 million from the general fund. That would keep us in a status quo operations. Option two, if you only got 30 million, which is what the governor's requesting, that you would cut the secondary tenants, and those secondary tenants, to reiterate, are ICU, telemetry, pulmonology, gastroenterology, interventional radiology, podiatry, interventional cardiology, telemedicine services, neurosurgical. So when you say the governor's on the same page, she agrees to that? And you said that GRMC would absorb these services if they were cut from GMH. This is consistent with the governor's.
This is real. This is real.
But you said the governor's on the same page.
Governor is aware of what I am saying. I truly am trying to lay it out as to what it is right now. And not all of those secondary tenants, Madam Speaker, is on the option two. The telemetry ward and the interventional radiology is not on option two. That would be on option three.
Okay.
But in regards to the outpatient services, which is all those services that were in there, that would actually be option two. Because those services do have a high cost, truthfully, sure. And then there is a revenue stream, just not as much as for them.
All right. I don't really have any quarrel or objection to what you are proposing as, like, that's what you're going to use the money on. I don't know. I guess you're basing it on what GRMC could provide if you shut those services down for GMH. I think that's a very shocking revelation for the people today. But if we cut those, we would be really at the mercy of GRMC. And I don't think GRMC necessarily may cover all patients, or they have the option, right, to cover patients sent over there by GMH.
I will be honest, I have been in communication with their CEO as well. I mean, what I have said here is nothing that I have not said in the public already. So in essence, I have spoken with GRMC. They are building their outpatient services. They're building their telemetry ward. They're building specialists, and yes. Again, there is such a thing called duplication of services, and I think that's a real discussion here on this island.
Sure.
And so, yeah.
Yes. There's also one hospital shutting down services, such as maternal health, whenever they decided to do that with very little notice, and the people of Guam had to scramble. And we are still in this state of scrambling, really. That's what I'm worried about. I mean, if we could say, oh, we got a great arrangement here, but we don't control that arrangement at all. So that's why I say we're at their mercy. And if this is what the governor's proposing, yeah, I'm hoping it can go farther than that. Like, we need some assurances that people who, I don't know, that they're going to work to get all people taken in by GRMC, if that's our solution. Also, there was, I know you say duplication of services, but I remember a time when I was a new senator and GMH was in trouble, and what they were proposing to us was, we need to build this unit, we need to build that unit, because these are the income or the revenue-producing units, and that's how we're going to save our hospital, was by building revenue-generating units. And this seems to be a total reversal of that, except that maternal healthcare will be revenue-generating if we can expand it, because we're exclusive, right? But yeah, I remember cardiology, everything, right? That's what their plan was. So you're nodding your head in agreement that you remember that, or you weren't?
Well, I was not here, but
Yeah.
yes. No, but honestly, that is, yes.
All right, that was the goal back then, the plan that was laid before us, okay. All right, well, there were some, so you gave us these papers regarding the ARP funds. These are critical, you call them critical infrastructure projects. Are these the same proposal for the 20 million, use of the 20 million that you gave us before? Because they look a little different.
So majority of them are, but as all things, when we are in the process of procuring, some of the cost estimates that we had were higher, and so we were able to actually, we regularly review this to make sure that we're still in line with the 20 million, and so when certain cost estimates for certain projects are lower, we're able to reallocate those for other projects that are needed in the hospital.
All right, are you using ARP funds for ventilators, BiPAPs, and drug library?
Yes, ma'am.
Those are capital improvements?
Yes.
Because the deal was the 20 million would be used for capital improvement. All right, and the use of this 20 million, Dr. Prince, is that going to, I heard one of my colleagues talking about the roof is leaking and other things. Is it, you say it's going to fix this plus the 15 million for the maternal child health care is going to fix the envelope. Is that going to fix the roof?
It is in the process of, and I cannot sit here today and say that's all we need to fix everything. That would be a complete lie. But all I can say is, yes, when we do with that MCH renovation, as we have shown you, that on that part of it, you will never have a courtyard again. That would be a wonderful thing. It would be all closed off. You have a new elevator shafts and things like that we discussed. On the other part of the hospital, putting in new air handling units will also help out in getting things, and we're actually putting in all the new ducting and things like that. And in regards to the envelope, yes, it actually has that as well in there. Is that going to be the last list? I doubt it. I doubt it. But I don't know at this point in time. But it is better than what we were before it. So.
Will that take care of the leaking roofs that we're aware of right now?
So the leaking roof incident that happened.
Oh, that was the water pipe.
Yeah, it was the burst pipe. It was not a leaking roof.
Yeah. The roofs were supposedly repaired already, just like the elevators were supposedly repaired already, just like the envelope was supposedly fixed during COVID to make sure that we weren't cross-contaminating, right? Things like this. So I don't know, these terms keep coming up, and so it just seems redundant to be the HVAC, same thing. We talked about that pre-COVID, and then during COVID, they supposedly put a lot of money into fixing that, and now we're back to HVACs on all these lists again. So this is the reason I'm just asking about these lists, because in your budget packet, there's also a list of CIP projects. They're called, and I was just checking whether they were the same or different priorities. These were capital improvement projects in the budget request. They're really not budgeted for, right, at all, again. So this is completely 100% reliant on ARP funds, right? The capital improvement to the current hospital.
Yes, what we asked for
All right.
was in regards to our operational budget, not our capital budget. That's why I said in that maintain, there's actually a buffer in there to start looking at capital budget as well.
There's a buffer in where?
In that maintain, I say 60 to 80 million a year. That's
Oh.
just to give us some freedom in there.
But
for
in your
capital.
request for 74,
No, ma'am, that's just operational budget.
that's what I'm saying. Okay, so that's been the case for several years. All right. Just wanted to ask about one of the items in your request is about, for this, on the nursing, it says, well, first of all, you're allocating $810,000 for miscellaneous under operations. Of the 810, the majority, or 377,000, is reserved for admin. 300,000 is for recruitment of, and then it says parentheses, foreign nurse recruitment. Last year, that was only $5,000, and this one is 300,000. Could you just explain that?
That is a recruitment initiative by our HR department to hire foreign nurses that will need immigration, a lawyer, and immigration papers and those types of things. So this is another initiative to bring more nurses. Since we are not able to hire as much locally, we're going to expand to the foreign nurse recruitment.
This is more efficient than traveling nurses?
Yes. Yes.
All right. And then there's a category of stipends. What is that? It says $25,000. Just wondering what that was.
That is for the Board of Trustees. They receive a stipend every quarter.
All right. Oh, yes, that's what I wanted to ask you, Dr. Prince. So if we decide on the option, I mean, obviously this is a proposal that you have made, and you and your team. Is this going to be something decided by the Board of Trustees, or is this going to be something laid out by the governor?
So what this will be is this is going to be a teamwork effort from all of us sitting at this table and even behind me. And then this will have to be presented to the Board of Trustees. This has to be. And then the Board of Trustees is going to have to either, and really work with us and say, nope, go back to the drawing board. This cannot happen. You need to redo this. You need to relook at that. And then once we get the final, and then it's actually then allowing the governor to then see it and go from there. But the Board of Trustees, like I said, everything that I presented on this has already been discussed with the Board of Trustees.
All right. And if we go with option 2, where we reduce some services or cut some services, as you have listed, concentrate on the ones that we keep, we still need, well, that's 30 million less. And you're saying, though, that our employees that we kept would be still efficient?
Yeah, so no, so we would have to disperse, right? We would have to actually look at, because again, each service has its own, has its amount of the staff, and that for me, I could, if it does go into public health, well, then they can just roll over to public health as well and be there with the service. We cannot keep at the current level. We always have to look at our labor. We have to.
You have to go down.
We do. We do. If we don't have the service, we can't do the labor, which is going to be, it has to be done, and it's going to be creative.
All right. And you've presented this, you said, in detail to the governor, the way you've presented it to us today? Thank you.
Yes,
okay.
ma'am.
And just one more item. There was a $11 million increase for nursing salaries. Is this just for pay raises or some other explanation?
It's the pay raises with the new nurse pay plan. So that has a domino effect on all the other personnel costs, like the differential pays. So if they're paid, for example, a 15% certification pay on a higher hourly rate, it's going to cause another increase. And then, of course, for the benefits, it will go up as well.
All right. And Dr. Prince, just one more general question. When you said that the mandate under 10 GCA Chapter 80 was for acute, chronic, and all other healthcare services, these items on the secondary tenants, you're listing them as secondary tenants, is that correct?
I am. Because again, if we're going to really look at cost-cutting measures and things like that, we got to look at services of what does GMH have to provide, what is on the island presently. But yes, again, I respect everything that everybody has said in regards to what's going to happen if we do close or actually cut these services, what's going to happen with our patients. And these are discussions. But when I look at the primaries, I discuss this with our team. These are the primaries, right? That has to happen for sure.
There was a time several years ago when the government of Guam was negotiating its health insurance contract for the government of Guam employees. And back then, it was exclusively, their hospital benefits were all through GMH. And when it got divided, or they had choice to go to whichever hospital and they are all covered, did that impact GMH?
I don't have the exact figure as of right now, but I can only ascertain that there probably is answer some, most likely.
Yeah, it was predicted to have significant impact. Do you know, Yuka? All right, just curious if that was also looked at. So you're pretty much saying that taking more patients is not going to help GMH increase its revenue necessarily because of the costs associated with it?
Yeah, Yuka and I have really truly gone after this in the Excel spreadsheet, meaning that I keep asking Yuka, I said, Yuka, what if we can bill $42 million a month? How much more are we going to get? Yuka would then tell me, well, maybe 1.1, maybe extra, not much. And so the question is really truly because again, once we know what our maximum can be, then we can kind of work our way down from there, and that's truly what we're looking at.
All right. Well, sorry, I didn't finish my earlier question, but the secondary tenants that you described, those are acute, chronic, and other healthcare services, though,
yes,
right?
Yes, ma'am. They are acute, chronic, and other healthcare services.
So you're saying we are going to cut services that we have mandated to take on ourselves.
Well, that's what concerns me, right? But the costs are this, and the revenue is this, and that's it. And that's yes. No, I understand what you're asking.
Okay, and I understand what you're proposing. I'm just saying I think we've evolved to that, right? To cover all these things, and that was because of the choices that we had in the time. Maybe no choice, and I'm very weary. I mean, I love GRMC, but I know very much that the government of Guam does not control that. We do not control the market. We do not control the private insurance companies. We can only control what the government of Guam can control,
yes,
which has been for all these years GMH.
Yes, ma'am.
And that's why we have subsidized subsidized the patients without insurance, and now work very hard to get them covered by Medicaid or other insurance.
Yes, ma'am.
But all right, well, I appreciate all your testimony and your frankness, Dr. Prince, and your work on this, and all of you. So thank you, Mr. Chair.
Thank you, Madam Speaker. There being no one else to testify on the budget of the Guam Memorial Hospital Authority, I want to thank everyone for attending this hearing and providing feedback and suggestion. The Guam Memorial Hospital Authority budget hearing is now adjourned. It is now 4:27. Please take care, and thank you for all participating.